participate in this great congress, please submit your abstract. For the juniors watching us, the registration deadline for the junior grant will be the end of February. Next announcement, the European course on pediatric neuroradiology, the 12th cycle module 2, is approaching very soon. It's held from the 1st to the 5th of February in Spain. And I'm pretty sure you can also watch online. Please check that on the website. You find the link on the ESPR website and the ESPR website because it's a joint organization of this course. And the third announcement, if you want to do or repeat the M1 musculoskeletal ECPR exam, we have a date for that. No, it's the 4th of March. And here you see the registration link. You also find this link on our website. So this is from the announcement. And today we have a very interesting webinar. It is organized by the... Can I stop the screen sharing here? It is organized by our cardiothoracic task force, and it is about cardiovascular imaging of newborns, a very interesting topic. And when I come to this in a daily routine, it's always a bit tricky. So I hope it won't be this tricky anymore after our today's talk. And this is my honor to welcome Professor Flavio Zuccarino from Barcelona, who will give us this great lecture today. He is professor at the University of Barcelona. He is doing adult cardiothoracic imaging and pediatric cardiothoracic imaging. He's the head of the cardiothoracic imaging Hospital del Mar in Barcelona, and he is responsible for the pediatric cardiovascular imaging in Barcelona. So I don't know how many hours his day has, but it's really impressive. He also has organized different courses on cardiothoracic imaging, and his special interest is on congenital heart diseases. It's my honor to welcome you. I could continue to introduce you, but we want to listen to your talk. So it's an honor to have you here. The stage is yours.
Thank you very much. Thank you very much for the introduction and presentation. It's a pleasure to be here, to be invited to this webinar. I'll try to share my presentation. Okay. I think you can see well?
Yes.
Okay. So thank you to invite me to speak about this interesting topic, that is cardiovascular imaging in newborns. And as you can see here, we have a lot of different pathologies that can affect newborn, and in which imaging technique and in which radiologists play a key role in the diagnosis and in the management of this patient. So as you can see here, we have a wide spectrum of imaging technique, and echocardiography represent the first imaging tool because has important advantages. The first doesn't use ionizing radiation. It has a high temporal resolution that is key to depict the cardiac structure in fetus and newborn that present a higher rate. And also color Doppler technique allows defining vessel flow. So these are important advantages to study congenital and vascular disease in newborns. However, sometimes we can have a limitation due to the operator. Let's say echocardiography is operator dependent, but the most important are that the visualization of vascular and complex cardiac structures may be limited with echocardiography alone, and also the relationship between airways or associated cardiovascular abnormalities that is key in the diagnosis and especially in the treatment of this patient may be limited. So we have to use, in this case, advanced cardiovascular imaging techniques as MR or as CT that are different among them. And why we have to use it. As I say, I want to show you at the beginning a real case, a patient with a newborn with an aortic coarctation. In this case, echocardiography performs very well to diagnose aortic coarctation in children and in newborns. We can see well here the location of the aortic stenosis, but sometimes we have accessory findings as this vessel that you can see here with a flow inside, and this was impossible to define the origin, the anatomy of this vessel with echocardiography alone. So we decided for two reasons, for a preoperative planning and to define the origin of this vessel, to perform a CTA, in this case, to define here the location of the aortic coarctation. You can see the pre and post stenotic dilated aorta, the subclavian artery, but we were able with this technique to define the anatomy of this strange vessel that was an anomalous pulmonary vein draining into the superior vena cava system with a real rare course surrounding ipsilateral pulmonary artery. In other cases, this complex cardiac anatomy, as I said, can be really difficult to explain to our colleagues, to clinicians, to surgeons, and to students. So this technique allows the possibility to perform a 3D reformation, MPR reformation, and to explain better the complex cardiovascular anatomy, as in this case. You can see here a patient, a newborn, with a truncus arteriosus and an interrupted aortic arch. We can define the type of interrupted aortic arch and the anatomy of the truncus arteriosus, and these images may be key to plan a corrective surgery. So which one we can choose? We can choose both CT and MR, and they have advantages and limitations. MR is certainly the best technique to assess cardiovascular tumors, to assess cardiac function, to study cardiomyopathy, and for the follow-up is really important technique. The most important limitation is that we have to perform with anesthesia, especially in newborn. So if we have to study a patient like this one that presents a cardiomyopathy characterized by hypertrabeculation with an important ventricular septal defect, we have to perform CMR, and we have to perform it well with anesthesia because offers findings as late gadolinium enhancement, as the functional evaluation of cardiac cavities that are not accessible to other imaging technique. And so we use it for the first diagnosis and for the follow-up. If we want to study other cardiovascular structure in newborns without anesthesia, we can have problems. So you can see here another case from our center with a newborn that has no significant perinatal history, that developed hypoxemia and cyanosis after birth. Echocardiography suggested here a possible persistent left superior vena cava draining into the left atrium. by CMR performed without anesthesia, we were able to confirm this diagnosis. But you can see here that even if we were able to perform also 3D formation, the quality of the image, the anatomy is not so precise as the one that we can obtain in this case with CT without anesthesia. And this is the corrective, the control CT after the corrective surgery, as you can see here with the any master technique. So about CT, we can display newborns any arterial or venous abnormalities. It's important for the preoperative assessment, is the technique that we generally prefer, because it's performed without anesthesia in newborn, but as an important limitation, that is ionizing radiation. You know that this is an important limitation always, and especially in children and newborns. But in the last years, radiation exposure can be highly reduced with new generation scanner. If we optimize our CT protocols, if we have last generation CT scanner, we can highly reduce this exposure. How can we work in this way? We can use two kind of approach. We can use a large coverage CT scanner. In newborns, we need from 8 to 16 centimeter scanner to cover all the thoracic cavity. And we can perform axial CT scanner with prospective gated. Normally, this gating, the cardiac gating, is performed in systole in newborn and children due to the high heart rate. In this case, you can see here the value 128, but we can work till 150, 160 heart rate per minute, and we can offer here a really nice preoperative image to our clinician and surgeon in a patient, as you can see here, with a hypoplastic aortic arch, here with stenosis and a ventricular septal defect. The other way we can use CT to reduce those is use a dual source CT scanner that allows to drastically improve temporal resolution. We use also here a single phase prospective imaging with a flash protocol that are a high pitch protocol, and in this case we can obtain a median dose that is really very low. 0.2 it's the median dose reported from these authors recently, as you can see here. And this is the way that we are working now in San Juan de Deo Hospital, in the center, in our hospital. Here you can see a practical case from our hospital. It's a newborn, 4 days old. Echocardiography suggests an interrupted aortic arch, and we want a preoperative assessment performed by CT. Here you can see the heart rate. Here you can see the very low dose we use in this kind of patient. We center our interest in the cardiac region, and we perform here the CT scan without bolus tracking in this case, and we obtain high quality image of this patient that we can use with this low dose later to perform MPR reconstruction, MPR reformation, to display all the structure that the surgeon and the clinician needs to plan their management and to plan their treatment of this patient, and also a nice 3D reconstruction to better understand this complex anatomy. About angiography, conventional angiography is not a technique that we use frequently, because use a very high dose, a very high X-ray dose compared to CT. So for this reason, the CT and the MR demand has increased dramatically in the last decade, but angiography has an important role in as a therapeutic option in the treatment of this patient, with the placement of stents, with the possibility of vascular dilation, with the use of unplatzer devices, etc. If we have an anatomy or a vessel of small dimension that we can be able to diagnose with CT or with MR, angiography could be the last technique, the technique that we will have to use in this case. And one limitation of conventional angiography is that it's bidimensional images. So in cases like this is a patient, is not a newborn, it's a 3 years old patient, but to understand the limitation of the technique is, I think it's useful. We can here diagnose the pulmonary sling that present this patient here on the left, but we can see with this technique the most important finding, that is the relationship between this vessel and the airways. So the airways compression is better seen with this 3D CT reconstruction that we can show to our clinician, to our surgeons, and also with virtual bronchoscopy from inside the airway. And the last technique we have to discuss is chest X-ray. Chest X-ray is not the best technique for a direct assessment of cardiovascular structure, is sure, but is always a technique that we can use in conjunction with echocardiography, because can offer the possibility to see different findings, as you can see reported here, that are important in the management of this patient. One of these, for example, is pulmonary vascularization that can be increased or that can be decreased in newborns with congenital heart disease. So an increased pulmonary flow generally is related to a left to right shunt, as in the patient you can see here with a large ventricular septal defect, can be related to pulmonary congestion, to left heart pathology, or a decreased pulmonary vessel, pulmonary flow, can be associated to other kinds of congenital heart disease, most common, tetralogy of Fallot, for example. So it can be the first technique used for a clear differential diagnosis. Here you can see a patient from our hospital. It's a newborn, and here you can see in this chest X-ray an important increased pulmonary flow with cardiomegaly, and this patient was here you can see the correlation with the CT images with a diffuse ground glass opacity. So why the patient presented this pattern in CT and in chest X-ray that you see are performed really soon after birth of this patient, because he has a complex congenital heart disease. Here you can see a very hypoplastic left ventricle and mitral atresia, and all the pulmonary veins were draining into a collector, that is this one, that communicate with the right atrium, but that was occluded. This is an obstructive total anomalous pulmonary venous return in the context of an hypoplastic left ventricle. And so here we have to act quickly, we have to solve quickly this obstruction to solve all this pulmonary congestion. So it is really important to perform quick this diagnosis and to plan the correct treatment that is surgical in this case of this patient. Another finding, for example, that can be useful in chest CT in the context of these newborns with congenital heart disease is a case like this. There's a patient is a newborn, 4 days, and echocardiography was not able to detect the aortic arch. So if we look to the chest X-ray, it's difficult to look at the aortic arch, but there is a finding that it's curious here. We are looking at chest X-ray of the 4 days newborn, and something is missing, because if you are familiar with the chest X-ray in this patient, and if you compare with a normal one, you see that here normally we have a large mass in the mediastinum, that is the thymus. And so the patient here presented the absence, was absent the thymus in the patient. So this suggests a possible DiGeorge syndrome, which is a primary immunodeficiency. And this DiGeorge syndrome can be associated with aortic disease and with other congenital heart disease. So as you can see here, the reported one, this patient had a ventricular septal defect and a clear interrupted aortic arch displayed here in the angio-CT. So we have seen now all the imaging technique that we can use in this kind of patient. Now we can we can look together some cases with of the different pathology that can affect newborns at the cardiovascular level. So one of the most frequent we can find are vascular ring. Vascular ring, as you know, there are a lot of possibility, a lot of a wide spectrum or possibility. The echocardiography is the first line technique that we use. We use echocardiography in fetal life. That fetal echocardiography can be the first technique to suggest the presence of a vascular ring. But in postnatal period, when the vascular ring must be studied, we began obviously with echo. If the vascular ring is diagnosed by echo and we want to plan a surgical treatment, or if we don't find a vascular ring clearly, or if we have any doubts, we can perform, in this case, CT or MR. In the case in which echocardiography rule out vascular ring, in this case, we don't have to perform the other image technique. So why we have to perform CT or MR? To define better the relationship with the surrounding structure and to study tracheoesophageal anatomy. And here you can see a real case of a patient with a fetal echocardiography that show here this sign, this Z sign that is associated in fetal echocardiography to double aortic arch. That is one of the type of vascular ring. And postnatal, we perform a CT scan, and here you can see how the CT scan, the 3D reconstruction, a 3D model from the CT scan better define the presence of this double aortic arch. They also show here an interrupted and atretic left aortic arch. And this is an important finding for the surgeon because this is the area the surgeon have to operate on. And we appreciate here the relationship with the trachea, with the airways, between vessel and airways, that is impossible to study with fetal echocardiography and with postnatal echocardiography. So when we have a complex anatomy, as in this other case, in which echocardiography can be not so clear in the evaluation of the double aortic arch, we can perform CT. In this case, was performed to show it, to confirm the four artery sign that is typical in this kind of patient, but also to define this anomalous vessel that was a large aneurysmatic ductus arteriosus, and at the same time we can define the tracheal stenosis related to this vascular ring in this newborn that presented dysphagia and wheezing. This information can be acquired also with by MR, but if we perform MR, as in this case, we have to perform general anesthesia in newborns. This is a case of an older patient that we perform not with anesthesia. And also the relationship between vessels and airways is not so precise, is not so easy to define in some cases, especially in newborns. For the reason, in different center and different reference center, computer tomography is used as the central second line technique in this kind of pathology. This is the workup that used in the Bambino Gesù Hospital. And also CT is able to add the possibility to a dynamic study, a 4D CT of the airways, because airways compression is not a static situation, it's a dynamic compression we can find in the airways. And so we can perform this if we have doubt. And as you can see here in this other example, you can see here a clear compression of the innominate artery at this level. You can see as the compression change during the respiratory cycle. Another pathology that we can find in newborns is aortic coarctation. Aortic coarctation is generally diagnosed by echocardiography alone, but when we want to plan surgery, we can use CT, eventually MR, and you can see here we can define better with CT the type of aortic coarctation in the relationship with the PDA and the relationship with the other supraaortic vessels. And this is we can obtain this information and with this MPR reconstruction with the 3D images, with 3D, for example, here are cinematic rendering from a really low dose CT in a newborn of 1 day and with a dose of 1 milligram per 4 centimeter acquired in free breathing. So this information must be already important for the surgeon, and the CT may be look in a systematic form. We have to systematically look to the location of stenosis, to the hypoplasia of the transverse arch, the presence of the PDA, if there are collaterals, and all these findings must be reported in our radiological report. And as I said, this information are really important, are key for the surgical planning, for the surgical decision to decide which is the best surgical treatment in the patient. Coarctation is frequent. What is not frequent, but we can find in newborns, is interrupted aortic arch. And so this patient present symptoms that are respiratory distress, cyanosis, congestive heart failure, and the therapeutic option generally is surgery, and surgical reconstruction can present a high mortality range. High mortality range from 15 to 20% in this patient. So it's very important to be able by CT to define the presence of the absence of interrupted aortic arch, the exact location and the length of this interruption to offer all the findings that the surgeon need to realize, to operate the patients. This interrupted aortic arch can be presented alone or associated with other congenital heart disease. So as you can see at the beginning, I presented the case with an interrupted aortic arch and the truncus arteriosus. This is another patient that presented an interrupted aortic arch with a aortopulmonary window, and it's another possible association. And here, obviously, this complete evaluation of all these findings together and the possibility to evaluate where is the pulmonary artery the aortopulmonary window and which kind of interrupted aortic arch we are looking, is very important to plan the surgical strategy. So after aortic disease, then we have to speak about pulmonary venous disease. And I want to focus on pulmonary venous return, and especially in total anomalous pulmonary venous return that can affect newborns and are a pathology in which the symptoms are severe. They can present with cyanosis, with congestive heart failure. As you can see here, there are 4 types of total anomalous pulmonary venous return. Type 1 is the most frequent, represent more or less the 50% of these cases. And chest X-ray can be the first imaging technique in this case, in some occasion, to suggest this diagnosis with this peculiar morphology of the mediastinum that seems a snowman, as you can see here, with 2 circular parts, one here and one inferior to the other. But not always is this case is presenting like this in chest X-ray. This is a newborn with suspected total anomalous pulmonary venous return supracardiac, in this case type 1, and the most important finding here is the increased pulmonary flow in the chest X-ray. Then if we look to the CT that we perform later, here with a little bit of imagination you can see the snowman sign here due to the presence of this vertical vein. But obviously what the surgeon want to know, or what your cardiologists want to know, is the presence of this complete anomalous pulmonary venous drainage with this vertical vein draining in the superior vena cava system. I said that this is the most frequent type of this anomalous pulmonary venous return, but we can also find cases like this with a type 3 with an infracardiac pulmonary venous return. So if we suspect this kind of anomaly, as you can see here, when we perform a CT or an MR, we have to implement the coverage of our study, including practically all the liver, because in this case, the drainage frequently goes to the portal vein. And this is the most rare, the infrequent type, that is type 4, in which you can see here the superior vein drain into the superior vena cava system, and the inferior pulmonary veins drain into the inferior vena cava system. And in this case, the reformation, the cinematic or volume rendering that we use in this case are really a good tool for the surgeon to understand the anatomy, to operate this patient. And here you can see the post-surgical CT, in which you can appreciate all the pulmonary vein draining correctly now into the left atrium. In the next minute, it's impossible to talk about all the congenital heart disease that we can see in newborn. I will focus on tetralogy of Fallot, that is one of the most frequent. And in tetralogy of Fallot, as for other pathology, chest X-ray is still important, because as you can see here, we have a special morphology in many cases that is a boot-shaped heart, due to the right ventricle hypertrophy with here the apex, and also associated to a poor pulmonary vasculature, a small pulmonary artery. In some cases, we also can find a right aortic arch, as in this one, or as in this one that is another case from literature. So when we have to perform CT or MR, because in tetralogy of Fallot, echocardiography performs really well. All the intracardiac anomalies, abnormalities can be detected by echo. But there are cases in which there are accessory findings, or we want to study better pulmonary arteries in which we have to perform CT or MR. In this case, for example, this is the patient of the chest X-ray I show you. We have a typical tetralogy of Fallot anatomy with an overriding aorta, with a large ventricular septal defect, with a small pulmonary artery. And here you can see the pulmonary arteries are difficult to study by echocardiography. In this case, they were really small. We also find an accessory finding that is here a unique coronary artery that originate from the left sinus and divide into the left and the right coronary artery. And here there was an important pulmonary artery stenosis. That was the reason the surgeon wanted to study this patient with CT to define the degree of the stenosis, the exact location of the stenosis, the dimension of the pulmonary artery. We also find a persistent left superior vena cava, and here you can see the morphology of the arteries, of the pulmonary veins, and also the strange course of the aortic arch that was difficult to define by echocardiography, with the ascending aorta and the proximal aortic arch on the right, and horizontal aortic arch here, and the descending aorta on the left. So a peculiar finding. What I want to transmit is that in this patient, pulmonary artery are generally pathological. We can see hypoplasia of pulmonary artery or stenosis. We can see enlarged pulmonary artery. We can see pulmonary atresia. So if we have to perform surgery as Blalock-Townsend fistula in this kind of patient, we have to know and define very well the pulmonary artery anatomy. So CT in this case, or eventually MR, are really important to evaluate the pulmonary arteries. This is another case from our center. You can see here a patient with a tetralogy of Fallot with a right aortic arch. But here the most important finding was this extremely dilated pulmonary artery due to the absent pulmonary valve. That is a rare finding that can be associated with tetralogy of Fallot. And here you can see the symptoms were related to the important compression of the pulmonary artery above the airways, generating this air trapping in the left and the right lung. So in this case, this imaging technique are key to plan better the surgery if it's necessary in this case to reduce this kind of compression. And we can use, as you can see here, also printed 3D models. In double outlet right ventricle, we also use this technique to better define anatomy, to better define accessory findings. Here you can see as with CT, we can differentiate a patient with tetralogy of Fallot from a double outlet right ventricle. There is a key anatomic finding that is mitral aortic continuity that is absent in double outlet right ventricle, as you can see here. And so with this finding, we are able to help the cardiologist, the neonatologist in this differential diagnosis. And we are also able to help our surgeon if they want to perform a reconstruction of this double outlet ventricle, because they need to know the distance, for example, of the ventricular septal defect and the pulmonary and the aortic valve to define if it's possible to regenerate, to create a new left ventricle outflow using a pericardial patch. So all this information are included in this CT scan. When it's not possible due to the high complexity, of the anatomy of the patient, as in this case, you can see here a patient with a dextrocardia, with a dextroapex, with a double outlet right ventricle, with an anomalous pulmonary vein returns. Can be difficult to explain all this finding only with images. We generally use to perform 3D models that can be virtual, or if we have to try to perform a surgery on it, can be also printed models with these materials that generally helps surgeon and clinician to define better the complex anatomy of the patient. About coronary arteries, just a slide, because we don't perform generally a study to define coronary artery anatomy and abnormalities in newborns. But we can find incidentally, as you have seen in the cases I presented before, a lot of abnormalities in the different congenital heart disease. So we have to focus on the presence of coronary artery, on their course, and if they present a usual path, a usual division or not. And a pathology that can be associated to a specific cardiovascular disease, for example, in newborns, can be something like this. Like this case, we can see a patient with a pulmonary atresia and an intact interventricular septum, and this patient can present sometimes a ventricular coronary arterial communication. And here you see in this case how this MPR reconstruction and this cinematic rendering imaging can display better this rare finding that is generally not so easy to see or to define with CT or with MR. And the other pathology that we can find in newborns and we can study with CT or with MR are vasculitis, especially Kawasaki disease. And here you have an example of a patient. In this case was 9 months old, but there was a previous study performed in another center. In this case, you can see how CT is able to define the presence of large aneurysmatic coronary arteries, and also the affection in this case is a systemic affection. So here you can see how we can appreciate different aneurysm at different level in the subclavian arteries, in the mesenteric and in the iliac and femoral arteries. So here with dual source CT, we can perform a flash study of all the arterial territories and focus our synchronization in systole only in this area, with a really good result and with a really low dose. And finally, we have to speak about cardiac masses. Cardiac masses or tumors can be diagnosed with imaging technique, and the multimodality imaging assessment is key for a correct diagnosis and management. We use always echocardiography as first-line technique because offer the possibility to look for localization, size and morphology of the mass, if there is invasion, if there is pericardial effusion, or if there is hemodynamic impact. But cardiac magnetic resonance, in this case, is without any doubt the best technique, because tissue characterization of this lesion is the key for the differential diagnosis. So we have the possibility to use late gadolinium enhancement, mapping images, first perfusion pass technique. Generally, cardiac mass in newborns are more frequently benign mass, but we also can find malignant mass. You can see a case here of a typical large hyperechogenic mass that affect the left ventricle. This is the image in cine sequences in cardiac MR. You can see an ISO or slightly hyperintense lesion compared to the myocardium. And when we studied this imaging, I said before, first pass imaging and late gadolinium enhancement are key, because here you can see there's no first pass perfusion image. There is no first pass enhancement of the mass, and there is no clear late gadolinium enhancement. Also, this lesion in T1 black blood sequences is similar to the rest of the myocardium. So probably we are speaking about a rhabdomyoma, that is the most frequent cardiac masses, benign cardiac masses in newborns. And as you can see here, doesn't present first pass perfusion and no delay enhancements. And in some cases, we can see a spontaneous decrease of volume of this lesion, as in this case, 2 months later, controlled by echocardiography, the lesion was really smaller. Other mass we can find with the same echocardiography appearance, hyperechogenic mass, can be this one. No, this is one large mass that in this case seem to be located inside the myocardium. It seems to be obstructive of the generating obstruction of the left ventricle. The difference here is that it's highly hyperintense into T2 sequences. There is no, as before, first pass perfusion, but there is a very, very high late gadolinium enhancement. So this is a typical appearance, a typical imaging of a cardiac fibroma that can be located both in left then right ventricles. And as you can see here, the typical delay enhancement is a high delay enhancement with a dark core, central core. So here you can see the surgery performed, and you can see the correlation of this large delay enhancement area and this fiber optic tissue inside the lesion. Sometimes it can be challenged to define and to localize these masses. Here, in this case, by echocardiography, you can see here a hyperechogenic very small lesion that was diagnosed by echo incidentally in a newborn, 50 days old. And here you can see the CMR with a slightly hyperintense lesion here in T2 and CNA images. There was no first perfusion pass. There was no late gadolinium enhancement. So it could be a rhabdomyoma, but in this case, if we have doubt, we can also use, as our colleagues from Bambino Gesù suggest, mapping technique. And here, if you can see here in the mapping technique, we can use T1 mapping, T2 mapping, and the extracellular volume. And these authors report that extracellular volume is the most important finding in this differential diagnosis. In this case, the patient presenting an ESV of 18% was compatible with a rhabdomyoma. Or in fibroma, you can see this is another patient with fibroma, and you can see the very high T1 signal. And I show the last slide of the presentation, that is also on cardiac masses. Sometimes we spend a lot of time to decide the perfusion, the delay enhancement image, if the lesion is infiltrative or not. Here you can see a clear cardiac mass here located in the left atrium. But the surprise of this case, this is a case don't understand at the beginning the diagnosis. This was not a myxoma as we thought, as for this image located apparently in the left atrium. This image, this mass, was located outside the heart. It was an amartoma that was a polypoid mass, as you can see here, and was located in epicardial fat near the interaxial groove. So these techniques are the best one to characterize lesion, but sometimes we can make mistakes. So in conclusion, what I want to say is that echocardiography is always the first-line technique in newborns. It's really important to know the advantages and limitations of all imaging techniques that we dispose. MR and particularly CT allows to define vascular and cardiac anomalies in their relationship to the surrounding structures. And with the latest technological advancing, CT is assuming an important role in this patient. And the systematic assessment is essential, as another pathology, to correctly define pathological structures, anatomy, and make an accurate diagnosis and establish an appropriate treatment. And all these things are possible thanks to a great multidisciplinary collaboration, a great multidisciplinary team composed by technicians, radiology technicians, as you can see here, anesthesists, anesthesiologists, clinicians, surgeons, radiology, and all the cardiologists, neonatologists, and all the staff that participates to the diagnostic process and to the treatment of this patient. So that's all I want to say this afternoon, and thank you to all my colleagues from San Juan de Diego Hospital.
Thank you very much, Flavio, for this great talk and this overwhelming presentation. We have lots of questions already. To the audience, if you have any questions for Professor Zuccarino, you can type them into the query and answer section. You find the button at the bottom of your screen. So let's start. Is there a role for CTA in the evaluation of low flow anatomy and pathology in babies? For example, veno-veno collaterals in gland or MAPGAS in pulmonary artery?
Okay, interesting question. When we have MAPGAS, we use to perform CT because spatial resolution of CT is better than MR generally, and so we try to study MAPGAS with CT, with low dose CT, to perform a map of these collaterals to the surgeon or to the interventional pediatric radiology if they need to treat these collaterals. About gland, it's a little bit complicated to perform CT in this patient because you have to choose different acquisition time, because if you administrate intravenous contrast and you use for example, bolus tracking technique on pulmonary arteries, the study is generally too much opacified. The structure are too much opacified. So in this patient with gland or with other shunts, just like Fontan disease, you can use MR, is a good option, or you can use CT, but using a late acquisition, a venous acquisition, generally at 70 seconds.
Very much. Next questions. Do you routinely evaluate pulmonary venous anatomy for pulmonary vein stenosis in patients with bronchopulmonary disease or chronic lung disease, or only if there is a clinical suspicion of pulmonary vein stenosis?
You mean if in a patient with pulmonary pathology, I look to pulmonary veins?
I think that is the meaning of the question, yeah.
Yeah, but I try to look to the pulmonary veins, to vascular structures and cardiac structure always independently if I'm looking to a lung CT or a cardiovascular CT. I try to look at them with by CT anyway. I try to always look to the anatomy, to the course, and to the eventual presence of stenosis and anomalous drainage.
Okay, thank you very much. Another question is the use of the beta blockers. Do you use beta blockers in neonates?
No, no, we don't use beta blockers because beta blockers, can diminish the heart frequencies, but not too much to have a good diastolic acquisition. We use in newborns, what we want to see with CT by CT or by MR is the origin of the coronary arteries and the course generally. So if we want to see this finding, it's not necessary to use beta blockers. If you want to study a lesion, for example, in adult, you want to study atherosclerotic plaque, you need beta blockers, you need nitro to have a large vessel, to study the degree of the stenosis. But in this case, we only look to the anatomy, to the course. So generally, it's not necessary to use beta blocker. We don't do it, and especially in newborns where the heart rate are 150, 140, it's impossible to decrease a lot the frequency. If you use systolic gating, you can have a good quality images with dual source CT or with axial CT in this patient without beta blockers.
Okay, that already answers another question. Do you use sedation with or anesthesiology with breath hold sometimes?
No, all the cases you have seen here are without breath hold because we don't use sedation, we don't use breath hold. It's the acquisition is so quick that we generally don't need to perform breath hold. The acquisition with axial CT is the time of the rotation of the gantry, so 0.3 seconds, and the same with the dual source technique with flash acquisition. So we generally don't perform breath hold.
Okay, thank you very much. Another question regarding the dose of the contrast medium. How much do we administer in newborns?
For the contrast medium, we use highly concentration contrast from 350 to 40 to 400, and we use a small amount, generally 1.5 milliliter per kilo, and we use a very low velocity of infusion of intravenous contrast. We use 0.5 generally in newborns of the administration. And we use a small amount of saline flush that is generally 7-8 milliliter to clean the conduct of the intravenous contrast. And this is the better way. We have found that all the structure are generally well opacified.
Thank you very much. Another question regarding follow-up of thyroid function or in newborns. Do you check thyroid function before or after administration of iodine contrast?
No, for the moment, it's a check that we haven't performed. It's an interesting idea. We will try to look at it in the future, but we generally don't do it routinely. If the newborn has no pathology, known pathology of the thyroid.
Okay. Thank you very much, Flavio, again, on behalf of ESPR for this great talk, for this interesting lecture. And thank you, the audience, who spent this interesting hour with us. It's 7 o'clock, so it's time to close the webinar. Please mark your calendars. Next webinar will be the first Tuesday of February, given by Maria Reisaki. I think it will be another very great talk. Maria is known for her educational knowledge. So please mark your calendars and register. Watch our social media channels. We will post the registration link there too. I already had the announcement at the beginning. If you want to rewatch this webinar, it is recorded. You can find the link in the members area on our website in a few days. So again, Professor Zuccarino, thank you very much. Thank you.
Thank you.
Have a nice
Pleasure.
remaining evening and goodbye.
Goodbye. Thank you so much.